In this module, I am going to discuss about the disorders under the category of nephritic syndromes in childhood or glomerulonephritis. What is the basic definition of glomerulonephritis? The hallmark feature is hematuria. This is an important point to be noted. This hematuria can either be a gross hematuria where the patient would present with blood in the urine. The typical color is cola colored urine. Okay. Hematuria can also be described as microscopic hematuria, wherein you see presence of RBCs in urine examination. Okay. How many RBCs are present? More than 5 RBCs per high power field in case of uncentrifuged urine sample, and more than 10 RBCs per high power field in case of centrifuged urine sample. Okay. This is how we define microscopically hematuria. Please remember, many conditions can be associated with hematuria. So if you want to say that hematuria is only due to glomerulonephritis, you have to have additional findings. And these additional findings include presence of RBC cast or urine analysis. And second is presence of dysmorphic RBCs. Dysmorphic refers to abnormally shaped RBCs. More than 20% of the RBC should be dysmorphic RBC to classify as a criteria for diagnosis of hematuria associated with glomerulonephritis. Okay, so don't forget, these two features are characteristic of hematuria associated with glomerulonephritis. In addition to hematuria, the other findings in glomerulonephritis include mild proteinuria. Why this word is important? Because massive proteinuria is associated with nephrotic syndrome. Okay, and these patients can also have edema, and usually the edema is of mild variety, which is localized to the pedal edema as well as periorbital, that is surrounding the eyes. That is where edema occurs in case of glomerulonephritis. And fourth important feature is the presence of hypertension. Please remember, hypertension is the main reason why we admit children with glomerulonephritis. So mainly we admit these children for monitoring of blood pressure and also to start medication in case if it is in a hypertensive range. Okay. And these children can also have associated oliguria. Okay. These are the characteristic features of glomerulonephritis. Now, let us look at some of the important conditions associated with glomerulonephritis. The overall most common condition is PSGN, which is an expansion for post-streptococcal glomerulonephritis. That is what is called PSGN. As the name suggests, it is a post-streptococcal condition or a post-infectious condition. So what is the pathogenesis? Please remember, this streptococcal infection initially is in the form of a respiratory infection like pharyngitis, or rarely it could be a skin infection. Okay, and this skin infection could be something like pyoderma or impetigo. Okay, so the initial event is the streptococcal infection. To be more clear, exactly which type of streptococci it is, group A beta hemolytic streptococci. Okay, right, that is the infection. That is the organism causing infection. Okay, now following an infection, there is a time period after which only glomerulonephritis develops. We call it as a lag period. Now this lag period is around few weeks. Okay, I will describe that in detail in the next slide. As of now, remember, few weeks following a streptococcal infection, glomerulonephritis develops. Okay. Now, at this time, that is the lag period, what happens is development of immune complexes. Okay. Now these immune complexes are composed of antigen, which is a streptococcal antigen, as well as antibodies, which is anti-streptococcal antibodies. They combine together to form immune complex, and that immune complex get deposited in the kidney, resulting in glomerulonephritis. This is the basic pathogenesis of glomerulonephritis. Okay, now a little bit in detail about the streptococcal association with glomerulonephritis. You have to know what are the strains causing this condition and what is the lag period. As I said, it could be a respiratory infection like sore throat or pharyngitis, or it could be a skin infection like impetigo or pyoderma. The strains associated with respiratory infections include commonly M4 and M12. The other strains include M1 and M24. Okay, and following a respiratory infection, the lag period is generally around 1 to 2 weeks. Okay, whereas for skin infection, there is only one strain, M49. Okay, and the lag period is 3 to 6 weeks. Generally, remember, respiratory infections associated with streptococci are common in the winter season, whereas skin infections are more common in the summer seasons. Okay, now let us look at what are the characteristic features of PSGN. First important point to note is which age group of children are affected. It is usually school-going children. And the typical age group is around 5 to 8 years. That age group, they present with PSGN. So any child in this age group presenting with features of glomerulonephritis, please think about the possibility of PSGN, especially when they give a history of preceding skin infection or a respiratory infection. This possibility is very, very likely because PSGN is the overall most common cause of glomerulonephritis. Certain investigation also will help you to say that it's a post-streptococcal infection. One is measurement of antibody titers, and the commonly used antibody titer is ASO titers. What is ASO? It is an expansion for anti-streptolysin O. Right. So that is one antibody titer which will be elevated in case of PSGN. If ASO titers are normal, but your suspicion for PSGN is very high, then you can go for estimation of other antibody titers. The next commonly used antibody titer is anti-DNase B titer. Okay, so that levels also will be elevated. Okay, so these are the two antibody titers which you can estimate in PSGN. The second important investigation which we can do is look for the levels of serum complement or serum C3 levels. Please remember, during the formation of immune complex, C3 or the complement is utilized for formation of immune complex. So what happened to the level in the blood or the serum? Obviously, it would be decrease. So low serum C3 levels are noted. These two are supportive findings in case of PSGN. Generally, remember, to diagnose PSGN, a combination of clinical features along with the lab features, namely the C3 and ASO titers, are sufficient. However, there are some rare scenarios where you have to do a renal biopsy. And the indications for renal biopsy are low C3, which is persisting for more than 12 weeks. And a patient who is having impaired renal function. For more than 7 to 10 days, then also you are supposed to do the renal biopsy. Okay, right. Remember, most of the cases I will not do a renal biopsy in PSGN. Only in this scenario I am supposed to do renal biopsy. And if you do renal biopsy, there are certain characteristic findings. One is seen on the immunofluorescence. In immunofluorescence, you will see deposits of IgG and C3, that is a complement, in the capillary walls. Okay, and this gives rise to an appearance called as the lumpy, bumpy appearance, or it is also called as starry sky appearance. This is the usual finding in case of immunofluorescence microscopy. And if you do electron microscopy, you will see subepithelial immune complex deposits which is called as the humps. That is a name which is given for subepithelial immune complex deposits in PSGN. These are the classical findings if you do biopsy in a case of PSGN. Moving on to the management of PSGN, remember this is a condition which is primarily treated in a symptomatic way. That means the patient's symptoms are treated rather than treating the cause. Remember, it is not an infection, it's a post-infectious condition. So most of the times this will settle on its own within a period of few days to few weeks. Okay, so all that is required is symptomatic treatment, especially for hypertension. You have to use anti-hypertensive medications. Okay, the commonly used antihypertensive medications are amlodipine and nifedipine. These are the commonly used antihypertensive medications. Now, as I said, the natural disease course is resolution within few days to few weeks. Okay, and some general guidelines are ASO titer and BP, blood pressure, will normalize by 4 to 6 weeks, and C3 levels, they normalize by 8 to 12 weeks. Please remember, in this particular condition, microscopic hematuria can persist up to 1 to 2 years. This is an important point, because for example, you ask a child with PSGN to come for follow-up after a few weeks or a month, and you do the urine analysis, you may find that microscopic hematuria is still persistent. But that is not a problem at all, because it can persist for even up to 1 to 2 years. Rather, you should focus on other finding. How is the clinical status of the child? And how is the blood pressure of the child? And how is the ASO titer? By 4 to 6 weeks, all these should have been normalized. Then you can say that the child has completely recovered from this particular condition. Okay, right. Now, here is an important point. When you talk about post-streptococcal conditions, I have discussed before that it can result in rheumatic fever. And the next thing which I have discussed now is PSGN. Right. Now, if you give antibiotics for a streptococcal infection, for example, a patient presented with a sore throat and you gave antibiotics targeting the streptococci. Antibiotic administration can prevent the occurrence of rheumatic fever. Very, very important point. Whereas antibiotics will not prevent the occurrence of PSGN. This is an important MCQ point. So even if you have treated the initial streptococcal infection with antibiotic, still the risk of PSGN is not eliminated. This is an important point and has been asked as an MCQ in your previous exams. So that is about the discussion of post-streptococcal glomerulonephritis, which is the overall most common condition causing glomerulonephritis in children. Now moving on to other condition which can cause glomerulonephritis. This is a condition called IgA nephropathy. This condition is primarily because of deposits of IgA in the kidney, and this condition is also called as Berger's disease. Okay. Now there are some important one-liners which are asked in this particular condition. First important one-liner is, this is a cause of chronic nephritis in children. Remember, PSGN is an acute nephritis, but this condition is chronic nephritis. And this condition is characterized by recurrent episodes of nephritis. So that is why I have put up this as a common point, that IgA nephropathy is the most common cause of chronic and recurrent nephritis in children. Now, a very important point is, like PSGN, this condition also can occur following an infection, but it is not a streptococcal infection. Any respiratory infection can be followed by an episode of IgA nephropathy. Okay, so recurrent episodes can occur following a upper respiratory infection. And here is an important point: the lag period, that is the period between respiratory infection and development of nephritis, is 1 to 2 days. This is an important point because in PSGN I said lag period is few weeks, but here it is 1 to 2 days. That is an important point of difference between IgA nephropathy and PSGN. Okay, right. Now, what are the other points of differentiation? If you do the investigation profile, that is C3 level and ASO titer, remember in IgA nephropathy, they are going to be absolutely normal. Why? Because this is not a post-streptococcal condition. So that's why C3 level as well as ASO titers are normal. Okay. So in all children, to establish the diagnosis of IgA nephropathy, you have to do a renal biopsy. Okay. And renal biopsy is very, very classical. It shows mesangial proliferation with IgA deposits. That is the primary reason why it gets the name as IgA nephropathy. For this particular condition, the management is with certain medications. Remember this point that 10 to 20% of the affected patients with IgA nephropathy can develop chronic kidney disease in adulthood. So when they become adults, they can develop CKD. So you should always keep these children under follow-up. And it has been found out that if you use ACE inhibitors or angiotensin receptor blockers, there is a decreased occurrence of chronic kidney disease because they delay the progression of renal disease. Very, very important point. They delay the progression of renal disease. Okay, right. Second important point in the management is you can use fish oil, which is rich in PFAS or polyunsaturated fatty acid, especially the omega-3 fatty acids. And this omega-3 fatty acid is supposed to be beneficial by decreasing the entry of macrophages into the glomerular mesangium. Okay. This entry of macrophages into the glomerular mesangium is an initiating factor for IgA deposition in this condition. So by preventing that, this fish oil or supplementation of PFAS can be very, very helpful in decreasing the progression of renal disease. So please don't forget two important things in the management. One is the ACE inhibitors or angiotensin receptor blockers, and the other one is the fish oil, which is containing lot of polyunsaturated fatty acids. That is about the discussion of IgA nephropathy. The last group of nephritic syndrome is a condition of hereditary nephritis called as Alport syndrome. Okay. Yes. Now this is a condition which is inherited. That is why it's called hereditary nephritis, and the most common mode of inheritance is X-linked dominant form of inheritance. Remember, this can have other modes of inheritance like X-linked recessive as well as autosomal modes of inheritance, but overall most common mode of inheritance is X-linked recessive inheritance. Okay, and this condition is characterized by a defect in the collagen, and the name of that gene is called as Col4A5, which codes for type 4 collagen. That's why it's called Col4. And A5 refers to the alpha 5 chain of this collagen. This is the defect in Alport syndrome, and that is why the name is called Col4A5. Okay. Now, in this particular condition, there is a triad of features which are noted. which includes hematuria, that is a manifestation of glomerulonephritis. Second in this triad is a ear manifestations or hearing manifestation, which includes high tone and high frequency hearing loss. It is a sensorineural hearing loss. And please remember, the hearing manifestations are the most common extrarenal manifestation of Alport syndrome. This is also an important MCQ question. And the third feature in this triad is the ocular manifestations. What are the ocular manifestations? Let's have a look at this picture. This is the slit lamp examination, which is showing the characteristic protrusion of the lens like this. Can you notice that? This is the lens which is protruding forward like this. And this is what you call it as anterior lenticonus, which is a pathognomonic finding of Alport syndrome. Very, very important question for you. Okay, right. Anterior lenticonus is a characteristic pathognomonic finding of Alport syndrome. So, the most important eye manifestation is anterior lenticonus. The other important manifestations include in the eye are corneal erosion and presence of macular flex. Okay, right. So these are the characteristic features of Alport syndrome that one should know about. And all patients with the suspected diagnosis of Alport syndrome should undergo two important tests. One is the biopsy. Biopsy will show irregular thickening and thinning of the basement membrane. Along with that, there is also presence of lamellations. And this appearance on biopsy is what is typically called as basket weave appearance. Basket weave appearance. Okay, right. Another important test which all of these children should undergo is a genetic testing. Genetic testing to look for the defects in COL4A5 gene. Okay. These two investigations will clinch the diagnosis in case of Alport syndrome. What is the treatment? Please remember that treatment can be at the best supportive treatment only in the form of ACE inhibitors. Now, ACE inhibitors, as I have said before, can modify the progression or decrease the incidence of chronic kidney disease in these children. However, ultimately, most of these patients, they develop end-stage renal disease by second or third decade. So, the only hope of survival in these patients is renal transplantation. Okay, so ultimately, all patients with Alport syndrome are candidates for renal transplantation. This is because that is the only thing which can prolong the survival in these patients. That is about the discussion of hereditary nephritis called Alport syndrome. And with that, we complete the important disorders under the category of nephritic syndromes in childhood.